Okay, well, good afternoon, and thank you so much for joining us for today on this webinar on Mpox, sponsored by the New York City Prevention Training Center and the New York City Department of Health. I'd like to introduce the first of our speakers today. It's Dr. Pathella. Dr. Pathella is the Executive Director of the STI program in the Bureau of Hepatitis, HIV, and STI at the New York City Department of Health and Mental Hygiene. She has overall responsibility for directing, evaluating, and coordinating the activities of the program, which consists of roughly 90 staff who conduct work in STI program implementation, surveillance, and field operations, and epidemiology, research, and evaluation. So welcome, Dr. Pathella, and thank you for presenting today.
Okay, here I am. Thank you so much, Gary. Thank you so much for the invitation. I'm always happy to have an opportunity to do these joint presentations with the PTC. And I'm just going to kick things off with be a little bit less than half of this presentation because I know that Dr. Zucker has some very important kind of more practical information to share with everyone. But I'm just going to give an overview of kind of like hot topics and the epidemiology of Mpox since maybe the last time a lot of people have heard about what's going on in this area. So in terms of a situational update, this is a slide that I stole from Dr. Zucker. What we knew about Mpox prior to the outbreak year 2022 was that it's been around for quite some time as a double-stranded DNA virus, but largely limited to specific localities and also limited in terms of transmission mode with human-human spread that occurred primarily within households. And then 2022, the summer of 2022 came along and everything changed. And we had an Mpox outbreak that kind of disproportionately affected New York City. We were an early epicenter of that outbreak. And that outbreak was due to clade 2 of monkeypox virus. This epi curve shows case data from 2022. We had a total of over 3,800 reported cases. You can see on this graph this epi curve, the steep rise in cases that we had, which peaked at the end of July, early August, and that was followed by a long tail that continued through most of 2023. So zooming now into 2023 and up until the present, you can see that for the majority of last year, we were really lucky and we had very low levels of detection and reporting to the health department between 2 and 20 cases per month. And that continued until the fall, until October. And then all of a sudden we started seeing kind of a pretty dramatic rise. And so from that time last fall until now, we're averaging 36 reported cases per month. There have been 250 cases reported in New York City since the beginning of this year. We had our peak number in January, and that was 51 cases. So looking at the epi of these cases, well, first of all, just so you know, on the left side of this graph or of this slide, we have a graph that shows the total number of cases that we had for each year. So in 2022, again, 3,822 cases. We had 203 cases in 2023. And then again, so far this year, we've had 250, or at this point, maybe just a little bit above, since these data are from June 8th. But all to say that in 2024, for the first half of this year, we have certainly eclipsed the total number that were reported last year. In terms of demographics, things are largely the same from year to year. Each of these bars represents a different year. The top one is 2024, the middle one 2023, and then the bottom one 2022. For each of these categories. And you can see that the vast majority of people who reported to us as Mpox cases are men, identify as male. Also, the vast majority are LGBTQ+. We have a fair number of unknowns in this category because we rely on case interview or patient interview for that information. And for the longest time now, we have been getting in touch with roughly 2/3 of cases who we can either contact or who are willing to talk to us and to provide this information as well. So if you take out that unknown category, we're looking at over 90% of cases that identify as LGBTQ+. And in terms of age, across the different years, pretty consistently here, over 40% of cases are between the ages of 25 and 34. So this does skew a bit younger. In terms of borough of residence, we have very few cases that are from Staten Island, but we see, cases distributed across the other 4 boroughs. And then in terms of race and ethnicity, again, we see cases who identify with each of these race and ethnicity groups. One thing to point out here is that looking at the 2024 data, about a third of the cases are white, about a third are Hispanic or Latino, and 15% identify as Black or African American. And that is rather low compared to the outbreak year of 2022, when we saw a higher proportion of cases in that group, Black, non-Hispanic Black group. And this really may reflect, and we think it does, the fact that probably disproportionately more cases are going undetected among that population. And we definitely saw this early on in the outbreak with challenges to accessing care that particularly affected that group. And so this is something just to keep in mind, that we have to really pay attention to the fact that we have missed cases here, and they may be in some groups and not in others. Our hospitalization rates, you can see here, the very low, between 4 and 8% of cases from year to year are hospitalized. We generally get this information also from patient interview, and so we do have a fair number of unknowns in this category. And then we also count deaths. These are reported by the provider or listed as a cause of death on a death certificate. And we haven't had any deaths so far this year. Very lucky, only 1 last year. We did have 6 deaths among New York City residents in 2022, and that really occurred kind of after the peak of the outbreak, when we were seeing these very, very severe cases that resulted in mortality. And then the other thing to note when it comes to characteristics of cases is that HIV or recent STIs are common among people who are diagnosed with Mpox. These are data from a multi-site study that was conducted early on in the 2022 outbreak. It showed that of Mpox cases, 61% were living with HIV or had a bacterial STI in the year before their Mpox diagnosis. We have measured similar co-infection rates among New York City cases, though it's a bit higher with the Mpox HIV co-infection, closer to 45%. All to say that it's important to do both HIV and other STI screening for people being seen for possible Mpox, and also to prioritize that population for vaccination. So moving on to some of the big news this year, there is an outbreak in the Democratic Republic of the Congo. Mpox is commonly found in the DRC. Cases are often detected and due to zoonotic transmission. But now we're seeing the largest surge of cases ever recorded, with so far, or since beginning of last year, over 19,000 suspect Mpox cases and over 900 deaths. This outbreak is widespread. It's reported in 23 of 26 provinces, concentrated largely in 2 of those provinces. And there are challenges to surveillance and testing and case ascertainment in these areas. The collection of epidemiologic risk factor data and genomic data in that region is often limited, but the data collected suggests that cases have stemmed from many zoonotic introductions and subsequent chains of household transmission, with children more likely to acquire infection through contact with infected animals and to bring infection home to household members, with the exception of 1 outbreak in 1 mining region in the DRC that was found to be largely driven by sexual transmission, with 29% of confirmed cases identifying as sex workers. Although there is evidence of sexual transmission in some localities in the DRC, there's no current confirmed evidence of widespread heterosexual transmission in other DRC provinces, and widespread sexual transmission in the US general population is unlikely, and I'll get more into that on the next slide. The concern with importation from Africa has to do with higher illness severity and case fatality that has been observed in DRC. So there have been no cases of clade 1 Mpox reported in the US yet, fortunate for us. CDC is continually assessing the overall risk to the US posed by the clade 1 Mpox outbreak in the DRC for 2 different populations. One is the general population, And currently the risk to the general population is assessed as very low. There are no known cases of clade 1 in this country, as I said, or in any other country outside of endemic areas, despite CDC testing a high proportion of presumed Mpox specimens with tests that can identify Mpox by clade. The virus could potentially spread from DRC to the US or other countries through infected travelers from the DRC. There are no direct commercial air passenger flights arriving from DRC or any of its neighboring countries into the US. And while the DRC outbreak has resulted in thousands of confirmed or suspected cases so far in 2024, similar levels of transmission are unlikely here because, for one thing, we have smaller average household sizes, increased access to improved sanitation and healthcare, and a lack of zoonotic reservoirs of disease. The potential for sustained heterosexual transmission of clade 1 is likely to be very low, based on the lack of widespread transmission in heterosexual networks during the 2022 clade 2 outbreak, and also from some insights that we have from modeling studies in the UK and by CDC. Moving on to the risk among gay, bisexual, and other men who have sex with men who have more than one sexual partner, and for people who have sex with MSM regardless of their gender, CDC assesses that risk as low to moderate. Health authorities have documented STI or sexually transmitted clade 1 Mpox in DRC in MSM in 6 cases during 2023, indicating that the virus could spread among these sexual networks in the US if those cases were, or if we had cases that were imported. During the ongoing 2022 global Mpox outbreak, most US cases were among MSM and their sexual partners, suggesting that this population could be at an increased risk for clade 1 infection if the clade 1 Mpox virus, monkeypox virus, were to spread here. But there is some level of protection and immunity among MSM and their partners following that outbreak in 2022, which might reduce the risk of infection if clade 1 Mpox were imported. In addition, the 2022 global Mpox outbreak, MSM reported behavioral adaptations that likely contributed to declines in Mpox incidence, indicating that similar changes might be expected in response to future outbreaks. However, and I'll get into this again in a few minutes, a minority of MSM CDC has estimated would benefit from vaccination have been fully vaccinated. That proportion is actually higher in New York City, but is still room for improvement. And all of this just highlights the need for ongoing vigilance, especially approaching or now being in the summer time when we can expect increased transmission to occur. We've had multiple channels of communication around increases in local transmission and the threat of clade 1, primarily with clinical partners with whom the health department has contracted partnerships, and then also with various community groups. And then most recently via this health alert from last month that really spoke to the update on case numbers, alert to the DRC outbreak, gave an update on kind of the this changing situation around vaccination, and then provided recommendations for testing, vaccination, and patient care, all of which you'll be hearing much more about from Dr. Zucker, and really pointed to the fact that treatment and vaccination strategies for clade 1 are similar to those for clade 2. So in terms of prevention, we know from early on in 2022 that Mpox risk was associated with higher rates of partner change. This is borne out in the data that we have from cases and also through modeling studies that were conducted by CDC that summer. And so you can see here that information on modeling the impact of sexual networks and the transmission of Mpox. And then we also know that there were several strategies that were adopted to prevent monkeypox or Mpox during that time. This is one study, the American Men's Internet Study or AMIS study. It's an annual online survey of cisgender, gay, bisexual, same gender loving, and other MSM in the US. In August of 2022, Emory University conducted a special kind of addendum to the survey with participants who agreed to be recontacted in order to explore their knowledge, attitudes, and practices related to Mpox, and found that there was, across all of these measures, about a 50% decrease in the number of participants of the survey who reported reduced number of sex partners, 50% reported reduced one-time sexual encounters, and half reported reducing sex with partners that they met on dating apps or at sex venues. So it's important that we in public health programs at federal, state, and local levels and healthcare providers in the community continue to deliver these tailored harm reduction messages to diverse communities of MSM, specifically that the messages are designed to reduce the potential for stigma and to build strength and resiliency. And here are some of the messages that we have been promoting ever since the outbreak a couple of years ago. Some harm reduction messages around getting vaccinated, first of all, and then during sex or other intimate contact, all of these different kind of measures that can be undertaken to reduce the chances of acquiring Mpox. And you can see them listed here. I won't go through them one by one, but these are ones that we still have on our website and continue to use in our communications with providers and community. So getting into vaccine effectiveness, thank you, Dr. Zucker, for this slide where you have summarized all of the different VE studies that are out there. I'll just point out here that the vaccine effectiveness that can be expected from one dose is pretty variable, but the take home here is that with 2 doses, it's always going to be higher, and it gets up to 86% for 2-dose vaccination from this one CDC study, which is also on this slide in more detail. It's one that New York City also took part of, and it showed that there was a vaccine effectiveness of 75% for 1 dose, 86% for 2 doses of the Jynneos vaccine, indicating substantial protection against Mpox, irrespective of the route of transmission or immunocompromised status, which were controlled for in this study. And then here's a second study that came out right around the same time. These are vaccine effectiveness data from, again, the CDC based on a matched case control study, in which cases were patients with an Mpox diagnosis or positive lab result. Controls were patients with an incident HIV diagnosis or people who were on HIV PrEP. And the vaccine effectiveness shown here was 37% for 1 dose, 69% for 2 doses, with a confidence interval that ranged from 48 to 81%. So fully not fully protective for sure, as one would expect. Rarely are vaccines 100% effective, but important nonetheless. And here are data about vaccination specifically in New York City. These are from 2022, so a bit dated. But one thing I would note is that we really haven't seen vaccination numbers and rates inch up too much since that time. There was definitely a big demand for vaccination during the time of the outbreak, and that has certainly dwindled. And I'm sure that has been the experiences among all of you as well. But with the invaluable support of providers like you, New York City had administered over 154,000 vaccinations that year. About 2/3 of them were first doses. So that second dose is really important to get into arms, but it's really been lagging behind. And the inequities that we see in that second dose vaccination coverage really is consistent when we look at categories of gender and age. So for instance, among 25 to 34-year-old individuals, of all of those 40,000 plus who got vaccinated, only 46% got that second dose. It's estimated, it was estimated during the outbreak, and again, this has not changed very much. CDC is saying that about 1/4 of the US population thought to be at risk for Mpox has been fully vaccinated. Vaccine coverage varies widely between jurisdictions, and reasons for that variability could include lower accessibility to the vaccine, as well as low awareness, having fewer vaccine providers in the area, lower vaccine confidence and demand for sure, and concern about stigma. Our vaccine coverage has always been higher here in New York City. We're lucky in that sense. At the end of 2022, it was estimated to be 89% for 1 dose and 45% for both doses of the vaccine. And so it remains important to increase vaccination levels, particularly again for completion. So you'll be hearing in the next presentation in more detail about the ACIP recommendations for vaccination. Vaccination of individuals is permitted for those younger than 18. That is something that became possible when Mpox was declared an STI, that that young adults and adolescents, minors could get the vaccine without parental consent. Providers should administer Mpox vaccine as part of routine sexual health services. Administration of additional vaccine doses is currently not recommended for most people. I know there are a lot of questions out there about boosters, and that has not been recommended, although of course could change with evidence to support that. Peak immunity is expected to be reached 14 days after the second dose of the vaccine. Most patients who've been vaccinated are expected to have cross protection when it comes to the two clades. And then another kind of hot topic in this area has been the issue of waning immunity. And we know back in 2023, just about a year ago, a health alert came out from Chicago showing that more than 50% of cases in a Chicago cluster were people who had been previously vaccinated. And so we all kind of sat up really worried about the what the messaging around vaccination would be. Then that was followed more recently by the study showing that antibodies after vaccination wane within a year of vaccination. However, there have been, other kind of points of evidence that really support vaccination, of course. And one is this very recent MMWR that came out in May showing that monkeypox virus infection after receipt of 2 doses was estimated to have occurred in only less than 1% of fully vaccinated people. And that comprises a small proportion of national cases. We have a little bit of a different picture here in New York City. So on the whole in New York City, in the US, that's less than 1% of fully vaccinated people. For our cases in New York City, looking at data from October of 2023 through the middle of April, about 25% of new cases had been fully vaccinated. So a little bit of a different situation here, but again, really focusing on the fact that while no vaccine is 100% effective and durability is unknown, infections after vaccination are possible. And so clinicians are recommended to consider Mpox as a possible diagnosis if there is a consistent clinical presentation, even in those who have been vaccinated. And I know that Dr. Zucker will be talking a lot more about what illnesses look like for people who are vaccinated, and also and hospitalization rates and how that looks like as well for people who are vaccinated, which is all positive news. So we strongly recommend vaccination for people at higher risk for Mpox exposure. Again, you're going to be hearing detailed ACIP recommendations, but what we have on our health department website is that people who are strongly recommended for the vaccine include clinical and research lab workers, people who have sex with men and identify as male, trans, non-binary, genderqueer, or gender non-conforming, anyone who would be at risk for Mpox through sex or other intimate contact now or in the future. And we've listed a few examples that fit into that category. And then anyone with close contact with someone who may have Mpox to get that vaccine as soon as possible and no later than 14 days after the exposure. So that is the issue of post-exposure prophylaxis with the Jynneos vaccine. Should be initiated as soon as possible after exposure, ideally within 4 days, which is always very challenging for us to find out, right, that someone has been a contact to someone who's a diagnosed case, to find out that contact information, get in touch with them, make that referral, get them in for vaccination as PEP. Within such a short window. But if a person is at ongoing risk for Mpox, the recommendation is for vaccination to be given, even if it's been more than 14 days since the last exposure. And this is an article that came out of colleagues here at the health department in Vaccine earlier this year. It really kind of highlights the fact that doing these studies of effectiveness for post-exposure prophylaxis are really, really difficult to do. And we used a method of a traditional kind of cohort design, which found effectiveness to be 78%, but then based on some really kind of complex modeling, it dropped down to 19%, and that had a very wide confidence interval around the 19%. So I think the jury is still out on just how exact this effectiveness is, but we do know that there is some benefit for PEP in general, and it's important to provide it as with the Jynneos, but also Vaccinia immune globulin is available for people. And then we want to put in a plug to encourage individuals that you see who have Mpox to disclose names of their close contacts to the health department when we reach out to them, so that those contacts can be referred for PEP. a few more slides here. Of course, important to discuss vaccination with patients as a part of broader discussions around sexual health, to provide a strong recommendation, and to administer vaccine or refer for vaccination, and then to document those doses in our citywide immunization registry. To recommend and encourage individuals to complete the two-dose series. The second dose should be given at least 28 days after the first dose, but it really can be given no matter how much time has elapsed since that first dose, and there's no need to restart the series. And I know that Jason Zucker is going to talk again more about the benefits of vaccination when it comes to subsequent infection. In terms of ordering and administering the vaccine, there have been a lot of changes on this front recently. As of April 1st, the vaccine began its transition to the commercial market, though there are still no cost federal supplies available until just around now. And then the vaccine will be made available through the VFC program for eligible adolescents and the VFA program for adults, likely very soon. So a plug to just identify processes and funds for ordering JYNNEOS on the commercial market. The no-cost vaccine is still available in short supply, and this is the email address to be able to put in those orders. We at the Health Department have been able to fulfill them until now, and can probably continue to do so on a case-by-case basis. And if you don't offer vaccination at your own facility, we have vaccinefinder.nyc.gov, which provides vaccination sites around the city for people to be referred to. And then finally, just touching back on this issue about reporting of immunizations for individuals under the age of 19, doses administered have to be reported to the CIR as required by public health law and New York City Health Code. And then for individuals who are 19 years or older, doses administered should be reported to the CIR with patient consent, which can be given orally or in written form. And with that, I'd just like to acknowledge several colleagues here at the Health Department who provided information for this presentation. And I will turn it over to Jason.
Thank you so much, Dr. Pathala, for your presentation. Really appreciate it. We are going to transition over to Dr. Jason Zucker. Dr. Zucker is an assistant professor of medicine at the Columbia University Medical Center and an assistant medical director of the New York City STD Prevention Training Center. He is trained in adult and pediatric infectious diseases and has extensive experience providing sexual health care to patients of all ages. He is also the point person on all things Mpox at Columbia University. So welcome, Dr. Zucker, and thank you so much for presenting.
Thank you so much. And can you hear me all right, Gary?
Yes.
Perfect. So we're going to talk a little bit about more of the clinical side of where are we now. So the goals today are talk a little bit about what we knew about Mpox before the 2022 outbreak, describe what we learned about testing, treatment, and vaccination during the outbreak, and summarize a little bit about what's still unknown. We're not going to spend a lot of time on epidemiology and transmission because I think Dr. Patel just did a great job covering that section, starting from where we were before. The only thing I do want to highlight once again is that we are still having cases, and these cases are being missed frequently because people are forgetting about it. Even though we're not having as many cases per day as we did in June of 2022, we still are having cases every day. And in fact, I have been messaged twice today so far with new cases of Mpox. So this just serves as a reminder that in New York City and New York State, we are seeing consistent cases. I do want to remind everybody about transmission because this is a frequent question I get. Whenever we talk about transmission, we get questions about should I worry about the bus or subway, the grocery store, clothing store, gym, salon, classroom, or any other place that I go frequently? And the answer is probably not. There are 3 transmission routes, including animal to human, fomite to human, and human to human, and can then spread via percutaneous, mucosal, and respiratory routes. Because of these different routes of transmission, the CDC does continue to recommend infection prevention and control with a gown, gloves, eye protection, and N95 respirator. And while I always encourage proper PPE use, it is important to remember that even when not used appropriately, transmission to healthcare workers and others is rare. We talked a little bit about transmission earlier, but most transmission is really occurring via human-to-human contact. Very early on during the outbreak and still continuing to the data we saw about more recent cases, we found out very quickly that most cases are occurring in men. Most are occurring in men who reported recent male-to-male sexual contact because the most efficient route of transmission is close skin-to-skin contact. Transmissions to healthcare workers have been very rare, primarily via Sharp's injury, which is a great reminder about not unroofing lesions and just swabbing lesions so that we reduce the risk of injuries to healthcare workers. I do want to address the issue of respiratory transmission straight on, because the requirement to use N95s is probably one of the biggest complaints I receive from healthcare workers. This article from Beeson and colleagues goes through the literature, demonstrating that we have little evidence of respiratory transmission in the real world. In fact, there have not been any human-to-human outbreaks attributed to respiratory transmission. The example I always use that here in New York City, many of our patients come to us via subway, and we didn't see large outbreaks occur on the subway like you'd expect if there was truly respiratory transmission. The authors here actually even concluded that based on the available evidence, the likelihood of human-to-human respiratory transmission appears to be low. However, more studies are needed. One thing that we did learn, and that's important to think about, is that we can get pre-symptomatic transmission. So these are patients who don't yet know they're infected. In the prospective cohort study on the left, they found that 5 of 6 participants, viral DNA was detected 1 to 4 days before the onset of symptoms. Additionally, in the second study, they did contact tracing and identified that pre-symptomatic transmission was likely occurring in 5 of 18 pairs of partners. And so while transmission is primarily via close physical contact, it can occur in the pre-symptomatic phase, which makes sense and may help us explain how the outbreak spread so quickly. So we learned a lot about rapid worldwide spread with substantial human-to-human transmission via sexual networks. We've learned that respiratory transmission is unlikely, and we've learned that pre-symptomatic transmission is possible and does occur. However, there's still a lot more to learn, even about transmission. How does the route of transmission impact presentation? What routes are most efficient for transmission? And does respiratory transmission play any role? And if not, can we remove the N95s? So now that we've finished epidemiology, let's talk a little bit about presentation and pathogenesis. Prior to 2022, we knew that there were really 2 clades of Mpox with pretty significant differences in mortality. Clade 1 expected to have about a 5 to 10% mortality, and Clade 2 with about a 1% mortality. We also suspected that pediatric and pregnant persons had worse outcomes, and we knew what the classic presentation looked like. This is what I call the classic presentation, or what you would have expected to see if you read a book on Mpox prior to the 2022 outbreak. The disease starts with a prodrome, similar to many viral illnesses. Symptoms like fevers, chills, headache, malaise, myalgias, and lymphadenopathy are common. After the prodrome, patients develop a rash that occurs usually before day 5 and most commonly on days 1 to 3. These rashes, as we'll see from some photos coming up, are firm, deep-seated, well-circumscribed, and sometimes umbilicated. They traditionally start on the face and spread to the extremities, including the palms and soles. And they classically progress through several synchronized stages. They can be extremely painful and last for up to 4 weeks. And this is the classic Mpox timeline, starting with an incubation period of 5 to 21 days, meaning that after significant exposure, it can be up to 21 days before you have any symptoms, although they most commonly occur around day 6 to 7. That's followed by the prodrome we described earlier, followed by an anathema, which are lesions that start in the mouth. During this period, you can have infectious virus in your mouth that can spread through kissing and oral contact before you may even know that you're infected. That's followed by macules, which are flat lesions on the skin. And because they're small and flat, they're very easy to miss. These are followed by papules, right here, which are solid and superficial, not yet fluid-filled. They're less than 1 centimeter in size and could easily be confused for acne. These can progress to vesicles, which are still small, but filled with a clear fluid. and then further progress to pustules, which are filled with a darker fluid consistent with pus. They can also become umbilicated in this stage, meaning they develop a hole in the center, which is very classic for this disease. After that, they start to scab, and it's important to note that the scabs remain infectious. Patients are not considered resolved until the scabs have fallen off and there's new, fresh skin underneath. While that's the classic timeline we know of, we also know that that's not exactly how it's presenting during this outbreak. During this outbreak, the rash could be the presenting symptom or could occur before or after the prodrome. While we're going to talk about a lot of other symptoms, the rash is still common and prevalent in most patients, but when it occurs is the difference. The rash can also have multiple lesions in different stages on the same body part and does not have to progress, is not synchronized in its progression. We're also seeing high rates of lesions on the genital and perianal and anal area, so high rates of genital and anal lesions. Along with that, proctitis is a new and pretty common symptom, often as the presenting symptom, with deep lesions seen when examined. Urethritis presenting with dysuria with urethral lesions, as you can see here, has been reported as well, and can be easily confused for a more traditional bacterial sexually transmitted infection, just based on the presentation of dysuria. Pharyngitis is another common presentation with mouth and throat lesions seen, and has actually been a reason for hospitalization as patients are unable to tolerate oral intake. Ocular disease from direct inoculation or autoinoculation has also been reported. And it's important to know that ocular Mpox is a sight-threatening condition, and so you want to pay close attention to individuals with ocular disease. Patients report significant lymphadenopathy, often in the region of their lesions. And finally, we're seeing multiple episodes of bacterial superinfection, particularly in the perirectal and genital region. And these are just some of the very common ways Mpox is presented during this outbreak. So the good news, if there's good news, is that mortality has been well below even that 1% figure we had expected. I think we're up to only 57 deaths now, which means the mortality has been around 0.17 to 0.18%, about a fifth of anticipated. However, we have seen severe presentations of Mpox, particularly in persons who are immunocompromised, and most commonly those with advanced HIV not taking antiretroviral therapy. Complications are almost directly related to the level of immunocompromise. You can see that pretty clearly from this chart on the right that lists out complications by organ system. The orange and longest line are persons with CD4 counts less than 100. And you can see that they have many more complications than those with CD4 cell counts 100 to 200, which is the purple or lavender line, than those with CD4 counts 200 to 300, which is the blue line, and those with CD4 counts greater than 300, which is the green line. Mpox in many ways takes advantage of immunosuppression, acting like an opportunistic infection. And there was actually a section recently added to the HIV opportunistic infection guidelines to highlight that important fact. So we know persons who are immunocompromised have worse outcomes, but what about other special populations? As a med peds physician who does sexual health, I was initially extremely worried about the implications for children. Going into the outbreak, older data we had from African studies suggested that the disease may be worse in those 8 and younger, with higher mortality in the younger age groups. Additionally, in the 2003 US Mpox outbreak that was attributed to prairie dogs, 29% of patients were pediatric patients, and they were more likely to be admitted to the intensive care unit, suggesting pediatric patients may do worse with Mpox. However, luckily, that's not what we saw. There were extremely few pediatric infections, 0 deaths, and a relatively low hospitalization rate. Additionally, like other special populations, information about Mpox during pregnancy was extremely limited. The literature prior to 2022 had a total of 5 lab-confirmed cases, 3 resulting in fetal loss, with Mpox identified in fetal tissue and placenta. While the maternal outcomes were okay in these cases, there were additional concerns because smallpox is known to be associated with more severe illness in pregnancy. However, the data on Mpox during pregnancy really remains limited. In 2022, the CDC put together a series that included 23 cases in persons who are pregnant or recently pregnant. 4 required hospitalization for Mpox. 11 received treatment with tecovirimat with no adverse reactions reported, but we still have extremely limited pregnancy outcomes. Additionally, the WHO lists 54 persons who are pregnant or recently pregnant, but does not have outcome data reported. So since the start of the outbreak, we've learned that most patients recover and mortality is lower than expected, which is good. That pediatric patients without notably worse outcomes, and that immunocompromised patients have the potential for a severe necrotizing form of the disease with disseminated virus and worse outcomes, including death. We still here have a lot to learn. Why do immunocompromised persons have worse outcomes? Does Mpox lead to iris in persons with HIV and low CD4 counts? And what is the impact of Mpox on pregnant persons and their fetuses? So let's talk briefly about diagnostics. Prior to 2022, we primarily had an orthopoxvirus PCR available only at lab response network labs. Testing quickly scaled up in commercial labs, and we learned that Mpox DNA could be found in seminal fluid, rectal swabs, urethral swabs, respiratory secretions, blood, and actually a variety of other body fluids. And there have been a lot of questions about whether skin testing is the best for making the diagnosis. What about all these other sites? Well, this study from France shows that Mpox virus concentrations are not the same at all sites. In this study, they use CT values as a surrogate marker of viral load. And you can readily see that the highest viral loads are seen in the skin, followed by rectal swabs, and then followed after a big drop by throat, blood, urine, and semen. The fact that skin lesions are easily visible with high viral loads really favors swabs from skin lesions as the primary site for making the diagnosis. Additionally, it's not just that skin lesions have the highest viral loads, but they also last the longest. This study from Spain over here, looked at viral loads and time to clearance in different compartments. And the time to clearance of patients in blood, semen, rectum, and pharynx was over a week faster of skin lesions. So skin lesions have higher viral loads and longer persistence, really making them a great site to make the diagnosis. However, the challenge is that what you don't see here is that while most symptomatic patients will develop skin lesions at some point, skin lesions may occur after the start of symptoms like pharyngitis or proctitis, delaying the diagnosis. Nationwide, the most diagnoses continue to be made from PCR from lesional swabs, with lesional swabs approved at local labs, commercial labs, and public health labs. None of the commercially available test kits include anything other than lesional swabs, but there are some academic labs that have validated testing of other sites. So clearly it would be beneficial to have the ability to test other compartments when patients are symptomatic. But what about when they're asymptomatic? Well, I showed you earlier that patients can have pre-symptomatic disease, but what about asymptomatic disease? Well, in this study out of Belgium, they retrospectively screened 224 samples that were collected for gonorrhea and chlamydia testing. They found 3 rectal samples and 1 pooled sample positive for Mpox virus. 3 of the 4 never developed any symptoms, and all 3 had positive serology suggesting asymptomatic disease. Furthermore, 2 of the 3 had culturable virus, suggesting the possibility of transmission. And so testing of non-lesion body sites may have a benefit in identifying pre-symptomatic or asymptomatic disease. I didn't include it here today, but Dr. Patella recently had an article published in JID that demonstrated positive serology as well in patients who had no known history of symptoms, again, suggesting asymptomatic disease. And hopefully she'll talk to us a little bit about that afterwards. So we learned that orthopox testing from skin lesions could be scaled up quickly at commercial labs, and that pre-symptomatic and asymptomatic diseases both occur, and that testing body compartments may allow for earlier diagnosis. And we really do need validated commercially available tests from other body compartments, as well as a multiplex lesion PCR. To help with the, now that it's less prevalent than it was a year ago, a multiplex PCR will help with those misdiagnoses when people forget to think about Mpox and are only testing for HSV or VZV. Now we'll talk about therapeutics. So prior to 2022, tecovirimat was approved for smallpox via the animal rule and available through the EA-IND, but concerns about a low barrier to resistance. There was limited data for cidofovir and brincidofovir, some data about in vitro synergy between tecovirimat and brincidofovir, and vaccinia immune globulin with some benefits in a case report for disseminated vaccinia. So if your patient has Mpox, what can we offer them? The first is to remember that most patients fully recover, and symptomatic treatment remains the mainstay of treatment. Pain management with proctitis and pharyngitis, and prevention of infection with genital lesions are all really important to help your patients recover. And again, most patients will recover, and we're just trying to provide symptomatic relief. Supportive care works for most, but not all patients. Some patients do require medical countermeasures. In terms of medical countermeasures, it's actually 3 listed here, but only 2 are going to be in an updated IND coming out soon. The medical countermeasures are all available through expanded access INDs. So they're really for people with severe disease or at risk of severe disease, like those patients with HIV and CD4 counts less than 200. Vaccinia immune globulin is licensed for the treatment of complications due to vaccinia vaccination. There's no proven benefit for Mpox, but we think about using it in cases where development of a robust antibody response may be impaired. And it may be an option for prophylaxis in exposed individuals for which PEP is contraindicated or not expected to work. I'll mention it only briefly, but trifluoridine drops. These eye drops are FDA approved for herpes infection of the eye and are thought to have activity against orthopox viruses. They have been recommended by the CDC in most cases of ocular disease. Next up are our first 2 antiviral medications. Cidofovir and brincidofovir are both potential agents against orthopox viruses. Cidofovir is an FDA-approved antiviral, initially approved for CMV retinitis in persons with advanced HIV. It's a competitive inhibitor to DNA polymerase, getting incorporated into the growing DNA strand and blocking DNA synthesis, leading to non-productive infection. The problem with cidofovir is there's significant risk of renal injury, and given the low overall mortality of this disease, it's rarely been used except for extremely immunocompromised patients with severe disease. Brincidofovir is a similar drug that was approved for smallpox using the FDA animal rule. It's a prodrug of cidofovir, and it's thought to have less renal toxicity. Given its approval through the animal rule, it's only available through an FDA EIND. And again, these drugs are both primarily used for severe disease in synergy with tecovirimat. Diseases not responding to tecovirimat, unable to take tecovirimat, or topical or injectable. So cidofovir in particular has been used intralesionally with some case reports of really positive results, including this one here from Emory. And it has been recommended weekly for up to 3 weeks for patients with these really severe lesions, not improving on oral therapy and after immune reconstitution. Next is tecovirimat, the drug that's probably been talked about the most during this outbreak. It was also approved via the animal pathway, which means there's no human efficacy data in persons with Mpox prior to its approval, and it's only available through an expanded access IND from the CDC. Some questions about tecovirimat because we have extremely limited data. Is tecovirimat safe? The CDC has now documented over 7,000 courses given through the EA-IND, and we're waiting to see but there's not been any sign of large number of people with bad side effects. And so it's likely safe. However, there's still a lot we don't know. Is our dosing of tecovirimat correct? There's evidence of lower levels of tecovirimat in persons with HIV, as well as patients who have more severe Mpox. Finally, will tecovirimat use lead to resistance? And I think the answer to this question is a growing yes. Initially, resistance was seen in immunocompromised patients with exposure to tecovirimat. More and more, we're seeing cases of suspected transmitted resistance. Most importantly, compared to all of that, is does tecovirimat work? And we really do have a mix of observational studies. Some suggest that it does, and some suggest that it does not. And so we need a clinical trial to know if tecovirimat works to treat Mpox. Patients deserve treatments that work, and if tecovirimat is not effective, we need to be searching and testing for a new treatment. If it is effective, we have to ensure that all people with Mpox who need it have access to tecovirimat. And so we have learned that tecovirimat is likely safe, but that it does select for resistance in patients with prolonged infections, and transmitted resistance may occur. But we really do need a lot more information about whether these drugs work and what's the best treatment or treatments for immunocompromised patients. Finally, our last section on prevention and vaccination. And Dr. Patella has covered a lot of this already. I do want to just mention that, and the the MVA vaccine was originally approved and available through the SNS, although it's now commercialized, as was mentioned. The ACIP recommends vaccination for persons aged 18 years and older with risk for Mpox. They've defined this as gay, bisexual, and other men who have sex with men, transgender and non-binary people who in the past 6 months have had a new STI, more than one sex partner, sex at a commercial venue, sex in association with a large public event where Mpox transmission is occurring, sexual partners of persons with the risk described and above. And most importantly, I want to highlight this for everyone, persons who anticipate experiencing any of the above. It's important that we remember and listen to our patients. Patients who are sexually active in somewhere like New York City and non-monogamous are likely good candidates for the Mpox vaccine. There are some special circumstances. Previous smallpox vaccination does provide some protection, but it may not necessarily be lifelong. Vaccination should be given to eligible people who were previously vaccinated against smallpox. Pregnancy is not a contraindication to the MVA vaccine, as it's not a live vaccine. Individuals previously infected with Mpox do not require vaccination. And there's this one line in there that I highlight just to sort of tell you what I think. An immunocompromised person who is diagnosed with Mpox after their first dose of Jynneos may be eligible to receive the second dose on a case-by-case shared decision-making basis. I will tell you that the CDC does not necessarily still agree with that recommendation, even though it's up there, as it looks like prior infection really does invoke a robust immune response. With commercialization, we are having challenges with vaccination. I have patients constantly asking me if I really still need vaccination. This was prevalent starting a few months after the outbreak died down. And it's really important today that we mention it to our patients and highlight to them how cases are still occurring. And I just got a text about a third case today, which is a little worrisome, and we can talk about later. The other thing is, how do we pay for vaccination since commercialization? So insurers are expected to cover it for patients meeting the ACIP criteria, as it is an ACIP recommendation. They mentioned VFC before for people who qualify for that. And then there are doses available through the city in a variety of different ways. But we do have to be a little bit creative to make sure that we can make vaccine available for our patients who need it the most. One of the biggest questions coming out of the past year was about reinfection and post-vaccination infection. And going back to the Chicago outbreak that got mentioned earlier, this study looked at 37 patients from that outbreak as well as around the world, 30 post-vaccination, and 7 who had prior infection. And what they found is that patients with prior vaccination had less severe disease, fewer lesions, diminished mucosal involvement, reduced analgesia requirements, and fewer admissions to the hospital. It's clear that there was protection from either vaccination or prior infection. Additionally, this study out of the University of Washington, they actually did Mpox PCR on rectal and pharyngeal GCCT samples collected at a sexual health clinic. They found that 1.1% of patients had asymptomatic or subclinical Mpox, making it relatively uncommon. But interestingly, those who were vaccinated were with 1 and 2 doses of the MVA vaccine were 4.4 and 11.9 times more likely to have asymptomatic versus symptomatic Mpox. So while vaccination is not 100%, it's clear that people who are vaccinated with 2 doses were 12 times more likely to have asymptomatic disease, meaning they're not having any of the severe symptoms we reviewed earlier. So we talked earlier with Dr. Patella about the self-protective behaviors being highly effective for a period, and vaccination is highly effective in preventing or attenuating Mpox. We do need a lot more information about how long vaccination will last, how long immunity lasts, and does PEP with the MVA vaccine fully work, and what is the benefit we're expected to see? So to summarize and take us home today, the 2022 Mpox outbreak was different and changed a lot about what we'd previously known about the epidemiology, transmission, and presentation of Mpox. We learned a lot about rapid spread through sexual networks, severe disease in immunocompromised patients, pre-symptomatic and asymptomatic live virus identified, that tecovirimat is safe but can lead to phenotypic resistance, particularly in immunocompromised patients, but also transmitted resistance is possible, and that the vaccine is effective for preventing or attenuating Mpox, and combined with behavioral change is a powerful combination. I can't stress it enough, but the current Mpox outbreak spread rapidly, was serious, and cases are still occurring, and we still need to know a lot more. And we'll stop and take any questions.
Thank you so much, Dr. Zucker, for your presentation. And thank you, Dr. Patella, for your presentation as well. If there are any questions, please enter them in the Q&A box. Dr. Zucker, we did have one question that came in about transmission. It was really about, the question was, can Mpox be transmitted in a swimming pool or at daycares? Are those things that we should be concerned about?
So swimming pool, I would think would be extremely unlikely. When it's transmitted via fomites, it's hard, soft porous items like linens and towels and things. In terms of the daycare outbreak, there have actually been several kids who've gone to daycare with Mpox, and we have not seen any large outbreaks. Again, I think this was a major concern early on, especially among children, where it would be easy to spread back and forth. But I think we've really learned that the spread of Mpox is really dependent on close and maybe prolonged skin-to-skin contact, much more so than you'd expect to see in normal behaviors in a daycare center. And so we have not seen outbreaks even when we have had kids go to daycares with Mpox. I don't know if you have more thoughts on sort of the epi of that one in particular.
I don't. I mean, that's spot on. When we look at, especially in 2022, we were really on alert for fomite transmission, and we had no cases at all where that was like an isolated risk factor. There was always some form of like skin-to-skin contact or household, sharing a same household with someone that resulted in transmission.
Thank you both. I don't have any other questions right now. Actually, somebody just put one in the chat. Given continued outbreaks, shouldn't boosters be spoken about now?
I think boosters have been in the conversation for quite some time. Jason, you would know better, I think, as part of the panel that talks about these evolving vaccine recommendations.
Yeah, I mean, I think it's always tough because we don't have data on vaccination. And the data from the DRC or among healthcare workers is that while immunoglobulins drop, your amnestic response remains pretty robust. And so while you might get infected, you should have still a pretty mild infection. And that does seem to be consistent with what we're seeing even this far out. So the question then becomes, what is the benefit of additional boosters? And are you going to have an increased reactogenicity to them, when you get a third or fourth booster, compared to the benefit where it may be, very short-lived to prevent disease completely, which is kind of what maybe we're seeing, but long-lasting response is already there for more severe disease. So I think we just need additional information to really be able to answer that question more clearly. And I see a question about can we, since it's no longer under emergency use, we can offer boosters, and they should be covered since we were never paid for before. I guess that's possible. I'm going to stay out of that one, but I guess it's theoretically possible.
And I'll just add one other kind of concern on, the horizon is the fact that so many people haven't even gotten that first dose, or if they have, they haven't gotten that second dose. And to be talking about boosters may introduce a whole other kind of equity issue, rather than focusing on, reaching those people for the first time.
I think that's a great point. Our focus really needs to be on getting those second doses in, because we know there's so many people who only got one dose, as well as identifying those people who haven't gotten any yet and trying to get some into them.
Great, thank you. We are actually right at time at 1 o'clock, and I don't have any additional questions right now in the chat. Just wanted to turn it over to both you, Dr. Patel and Zucker, if you have any additional comments or thoughts as we close this webinar out.
Just remember that it's still there and keep it on your differential, keep testing and working towards vaccination.
Yeah, ditto. And just thank you for everything that you're doing.
No, thank you both. And thank you all for joining us today. Please reach out to us if you have any questions, and we hope to see you at a future webinar. Thank you.